It's HealthView on your talk station, News Talk 640 WFNC.
And welcome back to HealthView. This is Dr. Angela Ruff, and again, our guest this morning is Dr. Alvin Atkinson, who's a cardiovascular surgeon from Carolina Cardiovascular Surgical Associates. So, again, Dr. Atkinson, thank you for joining us and sharing with us some great information about heart problems, cardio problems, and some surgical solutions for them. Before the break, we were talking a little bit about the different variations of stents, the solutions, and some of the successes that have revolved just from learning what didn't work so well and what's working better. So that's nice to hear that the companies are coming up with better designs. So what are some of the other options of surgery for the patients with cardiac problems?
Right. Well, if we to continue our discussion about coronary artery disease or blockages in your coronary arteries, the standard operation we've done since the late 60s is so-called coronary artery bypass. And that's typically done by taking various conduits. We use veins from the legs. We use arteries from inside the chest wall called the internal thoracic or internal mammary artery. And we use arteries sometimes from the arms called the radial arteries. Mm-hmm. And sometimes it's better to use arteries from parts of the body. Sometimes it's better to use vein. And there's many factors that go into the decision of which is best. Mm-hmm. Frequently, it's been shown that the internal mammary artery is probably the best conduit, and it's probably best used, if possible, for the LED vessel or left anterior descending vessel on the front of the heart. Mm-hmm. And that improves the long-term results of the surgery significantly. Mm-hmm. That's not always technically possible or in the patient's best interest because there are certain aspects of harvesting radial arteries from the arm or mammary arteries from the chest and even veins from the legs. Sometimes the veins in the legs are not satisfactory. Mm-hmm. So all those things have to be weighed by the surgeon as to what's the best operation, if you will, to bypass blocked arteries. And the bypass operation is simply a detour. If you have a bad road, instead of trying to repair the road, we simply put stents in it or some other technique to correct the road. We simply build a new road around it, and mm-hmm. it allows the blood to flow into the heart muscle around the obstruction and generally solves the problem of lack of oxygen to the heart, which is underlying problem in coronary artery disease. And the operation's been shown to be fairly safe. We have a generally mortality and a serious complication rate of less than 1% in our practice and in most established practices around the country. And we're doing it on increasingly elderly patients, people with other medical problems, and that's probably been our biggest challenge recently, is to operate on people with many other serious medical problems and elderly people who still need bypass surgery simply because, as we said earlier, they're getting heart disease somewhat later in life now because of protective mechanisms and because of the fact that they may be females. Right. So we end up doing surgery frequently on 75-year-old ladies who may have some other serious medical problems, and yet we get most of them through without any serious problem. And we are able to do bypass surgery on them, hopefully before they have a serious heart attack or other problems. Right. And some of these patients do better with surgery than they do with stents because as people get older, the calcium plaque the plaque in the arteries becomes calcified, and that makes them a little bit more difficult and dangerous to place stents. So frequently the cardiologist may ask us to bypass an older patient where it would seem like, well, the older patient might be better served with a less invasive operation than a major operation. But actually it may be a safer procedure to do bypass surgery on a patient who has calcified arteries than to try to stretch the calcium with it, as you might imagine, with a balloon and just place a stent in there.
Right.
So there's reasons in the consultation between the cardiologist and the cardiac surgeons that choices are made, of course, in the patient's best interest as to what would be best for the patient short-term and long-term, safest, and would have the best long-term result to relieve their coronary blockages.
Well, both my grandfathers had bypass surgery in their mid-70s, and they survived into their 90s.
Sure.
So it gave them definitely a lot more life.
Yeah, we've seen numerous patients that had surgery 20 years ago and are still doing fine without any major complications.
No, they weren't feeble. When my granddaddy was 90, he was up on a roof trying to build a shed. So, that bypass worked really great for him.
Right.
But yeah, so it's great to offer procedures and not, I guess, let age limit whether or not somebody gets to have it.
And we've operated on many patients in their 80s and even early 90s.
Mm-hmm.
I think the oldest patient I've operated on for double valve surgery was 92.
Wow.
And she basically did fine. She had her aortic and mitral valve replaced, and she was in her 90s.
Yeah.
And I would say probably at least once a month we operate on someone in their late 80s and early 90s. Usually for valve surgery, but occasionally bypass surgery, and majority of the patients go through the surgery. They're obviously, the recovery is a little bit slower, but they come through it without any major problems.
Yeah, well, what is it? They say 40's the new 30s, so...
Yeah. Well, we're moving into the generation where the baby boomers are going to become, the Medicare age, and we're going to have somewhere between a quarter and a third of our population is going to need fairly advanced medical care.
Right.
And the economic issues haven't been solved, but the technology is there, and we're going to have to learn to adjust to it, I think.
Yeah. Yeah, that's right. The baby boomers are retiring and will stop working.
Right. That's right. But they're still going to get medical problems.
Oh, yeah.
You retire, you don't stop. You probably get more as you get older. Yeah.
That's right. That's right. So I don't know if the kids of the baby boomers have the same work ethic as the baby boomers did. So that could create a financial problem.
That's right.
Some of the I tell you something that my mom just went through. She had A-flutter and AFib, and so she ended up having that. The fibrillation surgery, and it's kind of neat, what was involved. Of course, my basic.
Was she treated with a catheter from the vein?
She was treated through that. They did like a little cautery of to try to find that little nodes that kept firing odd. And what I thought was just so odd is that she's a very thin person, very athletic, and extremely particular about what she eats and cholesterol low.
But, cardiac arrhythmias, in this case, I guess she had atrial flutter or atrial fibrillation, are unrelated to coronary artery disease.
Mm-hmm.
Atrial fibrillation is a disease of older people. It's two major causes, risk factors for atrial fibrillation. And if we're talking about that, is age and hypertension. And so as people get older, particularly if they haven't keep an eye on their blood pressure, they have an increased risk of atrial fibrillation. And a fairly, to me, shocking statistic is that 20% of all Americans will probably have atrial fibrillation sometime in their life before they die. So we're talking about a fifth of the population may develop atrial fibrillation. We can prevent that with better control of high blood pressure or other things. It's uncertain at the present time.
Mm-hmm.
But there are two types of things, not to be confused. There's people that get atrial flutter, usually because they have congenitally abnormal pathways. And I have several of my family members that have had this surgery where they put a little catheter, if you want to call it that, or a wire up through the venous system into the right side of the heart, and they interrupt those abnormal pathways.
Right.
And that is very successful and is very helpful. And I think one of my family members had it once, and one had to have it a second time because they maybe missed one pathway or it regrew. But both of those people had recurrent episodes to the emergency room with irregular heartbeats, and they don't have that anymore. So that's kind of going away in their life. That's somewhat of a risk to them, obviously driving a car or something.
Right.
So and that's a different disease than atrial fibrillation per se. It can come on. Both my relatives were in their 30s and 40s when they developed the problem. And
wow, that's very young.
Younger. And but that's treated general by electrophysiology doctors. We call them EP doctors. And they're cardiologists that have special training in electrophysiology. But this technology is developed over maybe the last 20 years. But it's very efficacious. It's very helpful to patients with these abnormal rhythm patterns. and it avoids them from having to take a lot of potentially serious medications. They're not always successful, and I don't mean to say that, but they frequently are, and frequently can solve a lot of problems. But it's a fairly procedure is usually done within, not more than 1 or 2 days hospitalization.
Do y'all do this procedure in your office?
No, we're cardiac surgeons, and this is generally done by specially trained cardiologists.
I see. Okay. Well, it just happened in our family, so it's a little interesting thing we went through.
Right.
But yeah, we're grateful they had somebody out there who knew how to fix the problem. So.
Sure.
So if you wouldn't mind just maybe going into a little bit, I mean, I think probably a lot of people have heard of when somebody has a stroke, there's a medication they can get if they get it soon enough to perhaps reverse that. I know there's some reasons why they can't take that. If you wouldn't mind maybe just elaborating on that a bit.
Well, I'm not, be honest, I haven't been directly involved in all the protocols, and you might at some point get a neurologist on your program to directly discuss it, but I can give you some of the outlines of the thinking involved.
Okay.
And I think it's important for anyone who thinks they're having a stroke to call, get themselves to an emergency room, tell them when they arrive that they think they're having a stroke, because the current protocols, the sooner you intervene, the safer the procedure, and the more likelihood that if you're having a stroke, it can be at least attenuated or stopped. And I think the basic thinking is that most older people that are having strokes are due to embolic strokes from their carotid arteries or potentially from their heart. And if you can get a clot-busting drug, in other words, these are small clots that have gone up into the brain or blocking an artery, and if you can break these clots down with clot-dissolving drugs, which there are several available, including aspirin, you probably should be good to take some aspirin, typically this will either stop the progression of the stroke or reverse it entirely. But it has to be done within half an hour to 2 hours of the onset of the stroke. The time frame is the same is true of a heart attack, for that matter. If you think you're having a heart attack, you should come to the emergency room. They take you to a cath lab, and they can get the artery open. And I've had relatives of mine who've had their artery open within half an hour to an hour of onset of a heart attack, and they don't have a heart attack. They prevent it because the muscle doesn't die, which is what happens with a heart attack, because of a blood clot, because the blood clot is removed with a catheter and the artery is reopened with an angioplasty and a stent. So we didn't talk about that earlier, but it's an important concept that people should go immediately to an emergency room if they think they're having a heart attack.
Right. So call 911.
Call 911. Get emergency transportation to the nearest medical facility, ideally placed with an active cath lab. At Wake Medical Center, we have a 24-hour cath lab angioplasty team that I think stays in the hospital now 24 hours a day. I think at Rex they have a team that's on call 24 hours a day. It's not uncommon for me to see at Rex or Wake at 1 o'clock in the morning a cardiologist just completing an emergency angioplasty for an acute myocardial infarction. And I know many patients have avoided death or severe heart damage by timely rapid intervention for occluded artery. So I really can't emphasize that too much.
Right. And
we're talking about that. Another important concept is that every person, I think, should understand the use of automatic external defibrillators. They're in churches, they're in public airports, everything. They call it AEDs. They're on the wall. And the key factor there is that the casino study, which was written, you can look it up. People like to look articles up in the New England Journal 2 or 3 years ago, showed that 80% of the people who drop dead in our society could be saved if they could be defibrillated within 3 to 5 minutes. And past that, it doesn't do any good. So you have to use a defibrillator fast because the heart dies within, and the brain dies within 3 to 5 minutes.
Right.
But the majority of people who die suddenly in our society die of cardiac arrhythmias that could be corrected with a defibrillator.
Right.
So it doing CPR is helpful, but the key thing is, if possible, to get a defibrillator and use it, and that's why they're available in many public venues now.
Sure. Well, and even I think if you have, they're just so inexpensive. Well, relatively inexpensive what they were originally.
Right.
If you know you have heart disease and you've had problems.
That's a good question. People are debating that now, whether they should, buy one. And I don't know what the cost is on the market. I think several. I
think when they originally were out there, we got one for our office. It was about $5,000.
Okay.
And now they're around $1,000.
$1,000. So it might be worthwhile to get
a lot
one.
more idiot-proof too now.
Yeah, they're pretty. They've been shown that 6th graders with just a little bit of training can do as well as EMT technicians.
Yeah.
So they're meant to be simple for the average layperson, and that's why I encourage lay people to become familiar with the technology. So if they're in church someday and somebody collapses in front of them, they can save their life.
Yeah.
Because that's what they can do. And that's what 80% of the people who die in our society die of something that is preventable.
Right.
If they had a defibrillator available.
Right. Yeah. So hey, I'd get it and put it in your car.
Right,
Have it with you.
Probably should keep it in the car. Right?
Yeah. But we're going to just take a quick break to hear from our sponsors, and when we get back, we'll hear more from Dr. Alvin Atkinson, who's a thoracic surgeon, and we'll be right back after these messages.